In 2023, the EU lost far too many lives to stroke, heart disease, COPD, diabetes, and breast cancer. That's equivalent to the entire population of Barcelona lost to 5 chronic diseases. And by 2050, the number of lives lost every year could reach 2.2 million, roughly the population of Paris. But it doesn't stop there. On top of the staggering costs to life, chronic disease also brings enormous economic costs to our societies. In 2023 alone, these 5 diseases cost the EU about €530 billion, equivalent to 3.13% of the EU's combined annual GDP. Given Europe's strained health budgets and financial pressures from so many other challenges, this is simply not sustainable. Now let's imagine a different future. A future where we manage the rising tide of chronic diseases better for Europe's patients, healthcare systems, and societies. In Romania, scaling up care for cardiovascular disease could save more than 107,000 lives by 2050. Not only that, for each €1 spent, at least €1 is returned directly to the economy as people can stay in the workforce, meaning that the investment pays for itself. In Portugal, for every €1 spent investing in better diabetes control, €1.4 would be returned to the economy. Over 7,900 cases of retinopathy and 210 amputations could also be prevented each year. And in Sweden, providing comprehensive breast cancer treatment to women could return as much as 5 times the initial investment directly to the economy. Just imagine how many more people we could help live longer and feel better by better managing chronic disease in Europe. Imagine using those savings to invest in new breakthrough technologies to treat and cure cancer and rare diseases. Imagine improving mental health care services for our loved ones. Imagine funding the green transition of our societies and financing a stronger, more secure Europe for generations to come. We've imagined. Now let's take action.
Good morning and welcome to this FBR webinar on the case for investing in a healthier future for the EU. My name is Thomas Alvin. I'm Head of Health Systems Policy in FBR, and I will be moderating this webinar where we will be discussing the economic case for investing in health. Before we continue, please note that you can use the chat function if you have any technical issues, but that you should use the Q&A function if you have questions that you would like the speakers to address during the webinar. Now, access to good quality healthcare for all is, of course, a cornerstone of our European health systems. And the primary reason for investing in health systems, in prevention, in innovative treatments, is, of course, to improve the health outcomes for patients, for populations, including for those with previously untreatable conditions. However, in these times of slow economic growth, with strained public budgets and many competing political priorities, including to invest in defense and the green transition, increased spending on health could seem like an unlikely prospect. For this reason, it's important to make the case that investing in health can also have a positive impact on the economy and actually help European countries to achieve these other important goals. But to make that case, we need solid data. And for this reason, FBR commissioned a report from our health consult to look at the current and future burden of chronic disease in Europe and also assess what increased health investments would bring back to society in some selected areas. Now, a bit later in this webinar, we're going to have a discussion with a very exciting panel to discuss the results of this report and the policy conclusions for member states and the EU. But before we do that, we will first dive a little bit deeper into this report. And to do that, I'm very happy to introduce Dr. Emil Scaria and Dr. Denis Brun from our health consult, who will walk us through the main findings of this report. Emil and Denis, over to you.
Thank you, Thomas. Good morning to all. I'm Emil Scaria from our health consult, and I will present the main economic analysis findings of the investment case. for investing in a healthier future for the European Union. The main aim of this project was to develop an investment case to enable effective outreach and advocacy for long-term investments in health and innovation at European Union and national levels. As part of the project, we conducted a trend assessment and a detailed economic analysis to quantify the health and economic burden due to 5 major non-communicable diseases in the European Union. We then conducted 3 case studies where we estimated the ROI from increasing healthcare investment in Portugal, Romania, and Sweden. These results were used to formulate recommendations for health financing before validation of results and stakeholder engagement. Can we move to the next slide, please? To provide a brief overview of the methodology, we first quantified the economic burden of the 5 major NCDs, which were stroke, ischemic heart disease, chronic obstructive pulmonary disease, type 2 diabetes mellitus, and breast cancer across Europe in 2023, and then we forecasted this burden up to 2050. The economic burden consists of direct and indirect costs. The direct costs include the cost of treating and managing NCDs, such as the cost of drugs, supplies, salaries of healthcare professionals, and hospitalization costs. We multiply the unit costs by the coverage rates to arrive at the total direct cost. The indirect costs include the costs due to lost GDP and productivity losses due to these NCDs, as well as lost GDP due to premature mortality. The productivity losses include absenteeism and presenteeism. We then estimated the ROI from increased investment in health by comparing 2 scenarios. The first, in which we estimate the economic burden at current levels of investment, and the second, where we assume the increased investment leads to increased coverage and better quality of treatment. We then divided these costs by the cost of increasing the investment to come up with an ROI, which is expressed as euros saved per euros invested. Can we move to the next slide, please? So here are some of our key results. In 2023, more than 1.5 million deaths were caused by these 5 NCDs, which are stroke, ischemic heart disease, chronic obstructive pulmonary disease, type 2 diabetes mellitus, and breast cancer in the European Union. Next slide, please. If incidence and mortality rates remain constant, the annual number of new cases is expected to reach 7.4 million in 2050, which is a 16% increase from current levels, while the annual number of deaths will increase from 1.5 million to 2.2 million by 2050, which is a 50% increase in the number of deaths. As you can see, most of these deaths are caused by the 3 main NCDs, which are stroke, IHD, and diabetes mellitus type 2. Next slide, please. We also compared the health burden across the different European regions, and we found that relative to the population size, Eastern European countries face a disproportionately higher mortality burden from NCDs compared to other regions in the European Union. Next slide, please. When we convert these into economic losses, in 2023, the 5 NCDs cost the European Union more than 530 billion euros, which is equivalent to 3.13% of the combined annual GDP of these countries. And when we look at it into the future, next slide, please. The annual economic burden is expected to increase to 563 billion euros by 2050. Next slide. These are the results of the ROI analysis. The first case study was conducted in Portugal, where we found that investing in interventions to improve diabetes control can save more than 8,700 lives between 2023 and 2050. Annually, this translates to about 180 cases of stroke prevented, about 90 cases of ischemic heart disease prevented, more than 390 cases of end-stage renal disease, more than 7,900 cases of diabetic retinopathy, and more than 200 cases of lower extremity amputations that can be prevented. For each euro invested, these interventions would return 1.4 euros in productivity gains after 27 years. So COPD, scaling up interventions, could save more than 1,300 lives between 2023 and 2050 and yield a return of investment of 30 cents for each euro invested. Next slide, please. We also did the same for Romania, where we looked at cardiovascular diseases. Scaling up the prevention and management of cardiovascular diseases could save more than 107,000 lives between 2023 and 2050. And this includes more than 2,700 cases of stroke and 2,200 cases of ischemic heart disease that are prevented annually. For each euro invested, these interventions returned 1.1 euro in productivity gains after 27 years. Next slide, please. In the breast cancer case study in Sweden, we found that providing comprehensive treatment to women affected by breast cancer generated a significant productivity gain from reducing mortality or delaying mortality. On average, the intervention yielded a benefit of 4.9 euros for each euro invested. We could also see that there was a significant improvement in quality of life. Over 2,700 QALYs were gained annually over the intervention period. Next slide, please. So those were the key results of the analysis. It is important to note that we use the human capital approach for these calculations, which solely focuses on productivity losses and only captures the cost of premature mortality until the age of retirement, which, as we know, is increasing in Europe. Broader economic impacts were largely excluded, such as early retirement, informal caregiving, and social assistance. Interactions with other conditions, which could also exacerbate overall burden, like COPD comorbidities, emergency room visits, and long-term care services could not be included. We also know that most NCDs have a relationship with mental health conditions, and sufferers of these NCDs go through these conditions. These could also exacerbate the overall burden, but could not be accounted for in the calculation. It's important to note that accounting for these would significantly increase the ROI of investing in these interventions. However, we believe the human capital approach offers a conservative yet robust and pragmatic estimate, which can help inform policy decisions. I'd like to hand over to my colleague, Danny, to talk about the key messages and policy recommendations from this investment case. Thank you.
Thank you, Emil. So, as you have seen, this report has come up with the conclusion that the burden of non-communicable diseases in the EU is substantial and growing for younger people, people under retirement age, people who are actors in the economy. And of course, longevity and quality of life are also impacted at a later age. And there are significant costs which are created by non-communicable diseases for health systems, for societies, but also for the actors of production. So investing in non-communicable diseases, in the prevention, in the early diagnosis and the treatment of these diseases can offer major and substantial health benefits, both short-term and long-term, and they have also societal benefits. This demonstrates that one can have significant return on investment for societies when addressing non-communicable diseases early. Next slide, please. What we arrived at in terms of key messages in the end, clearly it's important to protect and expand the investment in health and in innovation. Addressing non-communicable diseases early, effectively, reduces the burden on society and on the productive tools of the society. Second, it really showed how important it is to conduct strong retrospective studies, strong economic analysis, to have good and solid figures to add to the arguments that we can bring in terms of health or in terms of humanitarian views. It pays. There is a positive return of investment to invest in addressing non-communicable diseases. Third, we found that really well during the case studies in the 3 countries that improving patient pathways maximizes the impact of health investments. Very often, we found that there were duplication, that there were delays, that there were queues, that there were things within the health systems that increased the costs without any benefit to the patients, actually even sometimes to the detriment of patients. So working on patient pathways is also a way of improving the return on investment. Clearly, this report shows that health is a strategic investment. Not only investing in health would reduce future health costs, it also reduces future societal costs. It improves the productivity, it improves the quality of the workforce. And definitely, as we see in European countries, that the age of retirement is pushed to a later stage, it will have a major impact on the economy. And what we found is definitely there's a need to improve the collaboration between the ministries of health and finance. Very often, budgets are conducted and discussed based on previous expenditures, relatively short-term approaches, and sometimes conflicting approaches to budget between centralized and decentralized entities. This collaboration between health and finance at the central and the regional level over long-term approaches, long-term plans are major elements that will bring improvement in non-communicable diseases and their impact on society. So these are the 5 main messages of our report. Over to you, please. Thomas.
Thank you. Thank you so much both for this very clear presentation. And I would like to come with a follow-up question to Emil at this point. I mean, as you mentioned, you pointed out that some costs for health systems and society are sort of outside of these calculations on return on investment. Like you mentioned, social assistance, informal caregiving, some other elements. Can you say something about, the difficulty in doing this type of assessments and getting a complete picture of the return to the economy and society, and the role of sort of data in this regard, and finding the right data for your models?
Yeah, thank you, Thomas, for that question. Getting a complete picture of the ROI when it comes to health investments, especially non-communicable diseases, can be quite challenging, particularly when you consider costs such as social assistance and informal caregiving, because informal caregiving is often unpaid, and it makes it difficult to quantify because it's not formally tracked. And valuing this kind of care, it can be complex economically because it involves considerations of the time spent by the caregiver. It involves the health effects on the caregiver itself. So another challenge of getting the complete picture of the ROI in such cases is the complex interactions between the NCDs and the NCDs in other comorbidities, which require long-term caregiving and support. So it's sometimes difficult to attribute these costs precisely to one disease, and that makes economic analysis challenging. With regards to the role of data availability on societal parameters is limited most of the time, and it can be inconsistent with recent data not available in most cases. And there's often very little publicly accessible data on informal caregiving and caregiver productivity losses. So I think incorporating these less tangible costs requires better data collection and having robust valuation methods. And improved data availability is certainly crucial for getting a more complete picture of the ROI.
Thank you so much, Emil. And I think we'll come back to some of these questions during the discussion, the role of data, the role of evidence, because of course, having this right, robust evidence is of course important to be able to convince budget holders, ministers of finance to invest in health. So we're certainly going to discuss this more. So again, thank you so much both for this very clear presentation. There is a lot to dig into here and unpack. And to do that, I want to invite our very distinguished panel. to turn on their cameras. While they do that, I would like to remind the audience that you can pose questions to the panelists or to the colleagues from Our Health Consult if you have questions about the report by using the Q&A function. So the chat function is for technical issues, but use the Q&A function if you have questions for the speakers. And we will try to address as many of those questions as possible during the webinar. So with that, let me introduce the panel. We have Dirk van den Steen. He's Deputy Head of Unit in DG Santé, in the unit responsible for the European semester and health technology assessment. We have Boriana Goranova, Policy Analyst and Economist in DG ECFIN, the unit for sustainability of public finances and public expenditure trends. We have Antonella Cardone, CEO of Cancer Patients Europe. And we also still have with us Denis Brun from Our Health Consult. So welcome to all of you. It's great to see you here. We're going to kick off this discussion with an opening question that I would like to put to the entire panel. So this concept of health is not a cost, but an investment. It's of course not new. We've heard it before, but there isn't necessarily that much success in translating this slogan, if I might call it that, into real action. Now, we have just heard a number of policy recommendations on how to facilitate investment in health. And I would like to ask all of you, is there anyone that you particularly agree with, or is there anything you think is missing and would like to add? So I would like to start with putting that question to Dirk.
Thank you very much, Thomas. And good morning to all. Yes, there is one recommendation that took my interest in particular, was recommendation 4. It's on the need, the necessity to position investing in healthcare as a strategic investment with a long-term payoff. And in that regard, I wouldn't be overly pessimistic. I can already tell you that what we've seen on spending on preventive care in the EU, that between 2014 and 22, we went up from the famous 3% of all spending on preventive care to 5.5% of all healthcare spending. And a lot of this, of course, has to do with COVID-19 and the immunization programs. But there's also other increases in investments there that have to do with the overall health system preparedness. And certainly we saw public health capacities reinforced for health systems. And non-communicable diseases, chronic diseases are certainly also part of this policy effort. And this is also confirmed in the mission letter for our new health commissioner. So thank you very much.
Thanks so much, Dirk. Over to you, Boriana. How would you answer this question? Sorry, you're on mute, Boriana.
Sorry for that. Good morning, everyone. And thank you for inviting me also to participate in this panel discussion. So to the key challenges that you mentioned, I would like to stress the one that you have already included in your report and we are working on, and this is the impact of aging populations in the EU on public healthcare spending. So we know the demand and expenditure will rise. We don't know exactly what will be the impact of non-communicable diseases, of infectious diseases, of new pandemics to come or not. But what we know for sure is that the EU population is set to age in the coming decades, and that elderly people have, in general, one or multiple chronic conditions and are exposed to higher risk of complications when faced with viral and bacterial infections. Therefore, yes, I would join and say that the focus on prevention to postpone the incidence of chronic diseases is key, both to healthy aging and to fiscally sustainable healthcare systems in the EU.
Thank you so much, Boriana. Antonella, over to you.
Thank you, Thomas, and hello, everyone. Well, I strongly agree with the statement that you mentioned, and we need to move beyond viewing healthcare spending solely as a cost and recognize its potential for long-term economic returns. And the history has shown that good health and economic prosperity go hand in hand. When people are healthy, they are more productive and they contribute more to the economic development of a country. So, however, we need to do a better job of translating this understanding into concrete action. This requires a shift in mindset among policymakers and budget holders. We need then political will and also basically a different accounting system for health. So instead of including health expenditures under current costs, health expenditures should be allocated under investments. And this is a basic operational switch that could make a significant change in how health is considered by public authorities. So I agree with the policy calls mentioned in the report. What I would add is a specific policy implementation. So at EU level, we already have an existing system that can be leveraged to better incorporate health into wider economic and social policy, and that is the European semester. So it provides a framework for monitoring and coordinating economic policies across the EU. At Cancer Patients Europe, last year, we have launched a manifesto with a call to action. And what we would like to see is the mechanism of the EU semester adapted to pilot the inclusion of specific health indicators, specifically cancer indicators. And some of those indicators are currently already gathered in different reports that the European Commission or OECD or other academic institutions already publish. But we would like to see a system in place where health indicators are taken into the same consideration as economic indicators. And we believe that the EU semester is the right place where this could be done and should be done. And doing so would be a significant step towards integrating health as a core component of economic policy making, and indeed truly show that this concept, health is not a cost, but an investment from rhetoric to practice.
Thank you so much, Antonella, and some interesting proposals there on how to build on the European semester. Also, your comments on how you account for healthcare expenditure. So I think we'll certainly get back to some of those questions and hear what the rest of the panel has to say about that. Denis, obviously you were very much involved in developing the policy recommendations and discussing with different stakeholders on the ground in countries. Was there anything that in particular stuck up to you when you developed this report and something maybe that, well, you hadn't heard before, or at least that was particularly emphasized and you thought was interesting?
Well, I would say two things. I mean, first would be what Emile has just mentioned about how much the various elements of the data are intertwined. When you look at what would be the result of investing into better diabetes care, for instance, you see that you avoid strokes or heart diseases. So clearly, these two are difficult to separate, and these are not discrete diseases. Definitely, the impact they have on mental health and the impact mental health has on how they are addressed is also important. And we did not incorporate mental health in this overall analysis. The second thing that was important for us to see when we discussed at country level was the lack of coherence sometimes in the health system, which made patient pathways complicated and costly. And you would have a lot of things regarding waiting time to get to appropriate care, sometimes the distances to get to care, the costs of transport, which are difficult to incorporate in the analysis, but which are really important. And then the importance after that of adherence of patients to whatever prevention and treatment that are asked from them, sometimes because the system has taken too long to get them convinced, sometimes also because the elements that would support the adherence are not there. We see that the support to patients is not present. they have difficulties getting their questions answered. We see that there is very little use of new electronic tools to support adherence of patients and to support the quality of the care that would be given to non-communicable diseases. So these two things were clear. What we also found when we looked at these health systems was sometimes the difficulty to combine centralization and decentralization. Decentralization was very often promoted to bring care closer to patients, to bring better efficiency at local level. At the same time, what was gained there was lost in terms of overall policies. Central policies get longer to be accepted, assimilated, and implemented at local level. And then we find that at the local level, people would care for what their voters are concerned about, which are very often relatively more short-term than would be necessary to address non-communicable diseases. So this is also an element that has to be incorporated, which we could not put in the report as such, because you cannot quantify it.
Thank you, Denis. No, it's a very important point. I think, investing in health is not only about money, it's also about governance and who does what and how do you get the right sort of governance systems in place in health systems. Antonella, I would like to go back to you quickly. As we had this case study on breast cancer in the report, and as it shows, increased investment in timely cancer care can not only improve outcomes for patients, but also bring substantial economic returns for society. What are, in your views, the main barriers that hinder the necessary investment in improved cancer care in European countries? Is it lack of evidence? Is it lack of budget? Is it governmental priorities? Or is it something else?
Well, this is a €1 million question. So there is definitely, we can identify a lack of political will that translates in a lack of budget and shifted government priorities. So those are certainly important factors, especially now under the current geopolitical circumstances where EU governments are quick to pull the shift away from health towards military defense spending. So this is in addition to the risks of governments prioritizing short-term budget considerations over long-term investments in health, even if those investments offer substantial economic returns in the future, as the FER report clearly and undoubtedly shows. So the data are, so there is also, so what we see is a huge discrepancy in between countries, huge inequalities in between countries. For instance, just to mention a few data, in Romania, there is an only 6% uptake for breast cancer screening programs of women aged between 50 and 69 versus a 66% average at EU level. So 6% versus 66%. So we believe that additionally to the economic argument, so there are other challenges that needs to be taken into place. And I believe that the most important is the lack of trust in the health system. This lack of trust is not only among patients, because I must say that from other studies that also we did at Cancer Patients Europe, there is no, the trust into the health system increases among patients, but there is a bigger non-trust into the health system among the general population. And this actually has been showed clearly also during COVID-19 with all those no-vax movements, etc. So it is important to build this trust. And that this trust can be built, we believe, through transparency. So transparency and more evidence shown to the general populations, and then of course to patients. But the evidence should be collected and presented, published to the general population in a collaborative way among different stakeholders. So that unity needs to be shown to the general population. And also there should be a clear, so this economic argument could also be shown very clearly to the population, especially in a moment of economic crisis as we are now, so that people see that screening or vaccines or prevention in general is not just a waste of money, because this is, I mean, as I said, it's not only among governments, it's the perception is also among people that prevention is useless, is not really beneficial to me. If even when the political will is there, the expenditure is there, for instance, in the case of screening programs well spread at this stage across Europe, still the uptake of people is very low. So there is no trust in the screening programs. So I think that this would be beyond or besides the economic argument is a challenge that collectively we all together should try to overcome.
Yeah. Good points there on the trust in health systems, and of course the role in patient organizations and helping building that trust. I would like to go back to you, Dirk, and talk a bit about the European semester, which was mentioned, and also some of the questions in the Q&As about the European semester. Obviously, this process originated from the perspective of sort of fiscal sustainability, targeting fiscal risks and need for efficiency of public spending back in the day. Do you think there is more acceptance today that health investments are also needed for sustainable public finances in the long term and economic growth? And do you find this reflected in the current semester process or other EU policies? And you're, of course, right now working on this year's cycle of the European semester.
Thank you, Thomas. Yes, well, as you said, of course, the European semester has its origins in the great financial crisis and then fiscal coordination. But arguably, it has already become more inclusive, comprehensive ever since 2010, 2011. Also to take on board health investments, to be clear, and to drive both the EU's not only economic, but also the social policy coordination. But a bit to what Denise said, it's a bit like diseases, right? Diabetes type 2 and cardiovascular, they sometimes overlap. And social policies, they also have economic impact. They have a cost, they have benefits. So it's a bit a similar argument. It is intertwined. But just to, the first big example, I think you could find arguably in the 2019 semester, where we had this country-by-country guidance on investment priorities for the current programming of cohesion funds. And currently, 21-27, if we look a bit, we see that we have some 13.5 billion euro. That includes the member state co-fund under the cohesion funds for investing in health systems. And a lot of the guidance there, the original horizon was part of the semester in the so-called Annex D. That was the 2019 edition. So already then you had the health investments clearly within scope of the semester. And then 2020, well, no surprise, all member states received the country-specific recommendation in the 2020 edition to work on the resilience of their health systems. And this was then followed by the Recovery and Resilience Facility, where we had the national plans. And the national plans also referred to the recent country-specific recommendations. And as a result there, we see 42.5 billion until 26 of planned investments and also reforms across all 27 national plans for healthcare. This was also clearly embedded within the European semester. So to answer your question, yes, health investments are on board and already have been on board of the European semester. Now, when you talk about the current edition, the 25 edition, what we see is, and this was already announced last December, that as we phase out the Recovery and Resilience Facility, there will be more room for more comprehensive, broader country-specific recommendations, so broader policy base. And in that regard, I would say that we're well placed under the European semester, better than before, when it comes to analyzing and putting on the agenda the performance of health systems, because since the 22 semester, all country reports contain an annex which has an assessment of health system performance, all 27. That wasn't the case before. And for quite a lot of them, the topics broached, raised in that annex make their way to the body of the report, and then still for quite a lot of them to actual country-specific recommendations. And we do have already indicators in there that have to do with how much as a share of their budget do health systems spend on prevention, what are the oncology mortality rates, how does a country compare? There's also indicators there on antibiotics use and so forth. And if you look at the focus of this semester, clearly in line with the competitiveness compass, with the Draghi report, there will be a clear focus on competitiveness. So that certainly has to do with what we call bridging the innovation gap. And I would say there that for bridging the innovation gap in healthcare, you also need to keep investing in your health systems. You need performant healthcare providers, hospitals that can participate in clinical trials. You need health information systems to help organize, identify the patients you want to recruit for your clinical trials. And all of these have gigantic positive spillovers for the governance, for being able to steer the cost effectiveness of your health system overall. So that's one area. And if you look at the competitiveness compass, but this was also raised in the Draghi report, where there was reference to the declining labor force and the need to have longer working lives, there certainly also is a lot to be said for investing in health, in healthy populations as a way to boost the productivity of our workforce, and hence also the EU's competitiveness. And in that regard, investing in disease prevention today, clearly it's key to enhancing our productivity and competitiveness tomorrow. And I could also say what we saw here today from the report, of course, and Antonella already referred to some of the other reports. We recently had, for instance, the synthesis report related to the cancer health profiles, where there was an analysis, and this is a joint report, Commission, Joint Research Center and OECD, where we presented an analysis member state by member state of the productivity impacts related to cancer. Before that, and you said my unit deals with the European semester. Yes, we also deal with the state of health in the EU process, together with the OECD and the Euro Health Systems Observatory. In 2016 already, we had a Health at a Glance report, which had a thematic chapter that looked at productive life years lost as a result of some of these main non-communicable diseases. So I think the case clearly is there to be made. There is also a link to the competitiveness and productivity agenda. At the same time, and we repeat, it should remain clear, health is worth investing first and foremost in health for its own sake. Health for its own sake. That's the first baseline. Thank you very much.
Thanks, Dirk, and that's very clear, and I think we all very much agree with that last statement. Moving over to DG ECFIN, Boriana, your perspective. I mean, what's the current perspective in DG ECFIN on healthcare expenditure, and do you see a benefit in these type of economic assessments on which decision on public healthcare expenditure improve the productivity of the EU economy through a healthier workforce? And to what extent would you say that your perspective is similar or different from that of health policy makers or stakeholders?
Yeah, let me start from the second part of your question. So I think that there is a broad societal consensus about the common objectives of our health system. So differences may emerge from particular operational context and the roles we have in the decision-making process or in the production or consumptions of healthcare goods and services. But as you said, we all agree that healthcare is important for economic growth but also for social fairness, as mentioned by Dirk, and has its role in fiscal sustainability, especially in the context of aging populations in Europe. So while the governance and financing of healthcare system are a national competence, the EU, as you saw also from the intervention of DG Sante, plays an important supporting role in this policy area. So with population aging, technological progress, and the need to invest in more resilient healthcare systems to meet future crises, health spending is expected to consume an ever greater share of the economy. And this is what we are trying to put also in quantification. And with the work that we're doing on the aging report together with member states and in the Economic Policy Committee, in the latest projections, we see that public expenditure on healthcare in the EU is expected to increase by 10% on average due to aging in the next 4 decades. And this is only healthcare spending, excluding long-term care spending, both health and social, the health and social parts. So also from other scenarios of our projections, we can see that future longevity gains, if spent in good health, this increase can be cut by half to 4% in the next 4 decades. However, we can also see that if we do not manage to decrease the incidence of chronic diseases and also to improve the treatment or to not have the healthy aging as we are all hoping to have, and that longevity is spent in bad health, then public expenditure in the EU will rise by 16%. So what we can conclude is that aging will put upward pressure on public healthcare spending, and member states will be affected to a different degree. And this will lead to a significant increase in fiscal risk, especially for the countries that already face that sustainability challenges in the medium and long term. And this is just to put in context also the work that we are doing and the maybe a little bit narrow perspective that we are taking on by at the same time looking at the system, the health system as a whole, and suggesting jointly with member states structural policy reforms that can improve health outcomes and decrease at the same time the efficiency of healthcare, so that increased public expenditure on healthcare can be limited.
Yes. No, thank you. And it's a interesting and important perspective. We need to do healthcare investments that are the right ones. That of course takes money, but and we need to do it to make sure that healthcare expenditure in general doesn't grow in an unsustainable way due to aging population. So it's we need to find the right type of interventions and doing the right thing. And I would like, if you're allowed to just have a follow-up question. And Antonella mentioned, that health spending should be accounted for as an investment rather than as an operational cost. We also have, since last year, a new EU economic governance framework that, of course, sets these kind of fiscal rules that the Commission is a watchdog for. Could this new framework help enable strategic investment in health systems by member states? And if so, what's needed for them? What kind of tools and evidence are needed for them to do that?
Yes, indeed. Among the main objectives of the new economic governance framework, next to strengthening member states' debt sustainability, is to promote sustainable and inclusive growth. And this can be done through growth-enhancing reforms and priorities investments. We have mentioned the green and digital transitions, defense, but also any investment in an inclusive and resilient economy. So now we have the tools at European level next to the annual recommendations in the European semester and the country recovery and resilience plans. Next to them, we have the new member states' medium-term fiscal structural plans. And especially for member states with semester recommendations on fiscal sustainability or accessibility to healthcare, They may include investments and reforms in the area of health to address these recommendations in the medium-term fiscal structural plans. And here, I also want to stress that these plans are either 4-year or 7-year plans, but they have also a midterm period to look into, for which healthcare expenditure due to population aging are also included. So this short-term focus should be overcome through this increase in the period that we are looking at. And if you look at the so far adopted plans, we can see reflected in them the ongoing major investment effort in all member states to improve the resilience of their healthcare systems. As Dirk mentioned, already the EU is supporting them with 30, so he mentioned 35 in total for the EU funding mechanisms, but I would also mention the 38 million euros from the resilience and recovery facilities, which are supposed to help member states to advance the structural reforms and investments and healthcare. And let me conclude by saying that for a more resilient economy, and public finances, other instruments that can be used jointly by the Ministries of Finance and Ministries of Health in collaboration is bringing together the economic and health policy perspectives through tools such as cost-benefit analysis, as you have done it in your report for health policy interventions, but also spending reviews to identify inefficiencies or performance-based budgeting. There are also many others. We have actually issued a joint report with member states where we are discussing, we have discussed what is possible to be done. But again, to come back to also what Antonella said, what is very important is that we can have this analysis, but implementation is key. Yeah. Even if we put everything available to patients and the health workforce, then still more needs to be done as to have the right use of what we have achieved. And for implementing reforms, it's never that straightforward as we can put it on paper. It's a very complex endeavor. And we're looking forward to having more ex-ante, but also ex-post evaluation of policy reforms, and to be flexible enough. As we know, structural reforms are very complex, and they may also need investments as to even achieve savings in the future. But implementation is key, and monitoring the implementation is also key.
Yeah, no, that's clear, and thank you for that answer. And I think it's interesting what you said on the new fiscal governance rules, that they can overcome this kind of short-term perspective that was also highlighted in the report, these annual budget cycles, and maybe member states can be helped to get a more long-term view on investments. So thank you so much for that. I would like to look at the Q&A and look at some of the input from the audience who have been patiently listening. So Jean-François Lang just makes a comment on emphasizing the key role of vaccines, R&D and vaccinations to prevent NCDs in Europe when it comes to cervical cancer, flu, and cardiovascular impacts. We have there is also a question from Troels Sørensen on what is the panel's view on return on investments in health, in investment in health system infrastructure and access to current best standard of care versus investment in innovative therapies. So do you invest in innovation, or do you invest in whatever is standard of care? I don't know, maybe Dirk or Antonella could have a view on that. John de Masner put a comment that we have to make sure that our screening doesn't lead to overdiagnosis, and that the criteria for screening by Wilson and Jungner are still very relevant. And Then we have a question from Luca Delac with a question to DG Sante and DG ECFIN. How do you plan to collaborate to ensure that health and well-being indicators are integrated into European semester? And what steps are being taken to develop and implement well-being indicators? I think, Dirk, you already talked a bit about, the indicators you're already working with. So I think to some extent you have already addressed that perhaps, but if you have some quick comments, very, very quick on some of these questions. So investment, do you invest in current standard of care? Do you invest in innovation? I don't know if Dirk, Antonella, of course, Boriana, Denis, if you have any very quick answers to those questions.
Well, maybe I can answer very quickly to this innovation versus investment in infrastructure. So I believe that one goes with the other. We cannot like if there is innovation and then we cannot deliver the treatment because there are no infrastructure to deliver the treatment, then it doesn't make much sense. So I think that they go hand into hand with each other. So and I would really find it difficult to prioritize, to be frank. So
Yeah.
they must go together.
I have a similar reflection, Thomas, but I already discussed a bit how you need to invest in your health system also so that they can be conducive to innovation. It's a bit of a similar story. If you don't have the diagnostic capacity, how will you, in a proper and cost-effective manner, be able to roll out innovation? That's just one clear example, which is more and more relevant as we are in the era of more precision medicine ever since Herceptin, trastuzumab. So you need that capacity. And that's just one example how both should go hand in hand. And as regards the cooperation with ECFIN, I can assure you we work very well together. We have regular meetings, we exchange emails, we coordinate for the European semester. It's been like that for as long as I can remember. Boriana, please confirm.
Yes. Yes, I agree with you that when there is no consideration actually that we can take in part. We have to have this broader view. And when taking decisions where to invest or where to spend, and I would really advocate for not making this strong division between investment and spending. In economic terms, we know what are operative costs and we know what is meant under investment. Investment is more infrastructure, and then when you run it, you have operational costs. There is no problem in this. Even thinking in these terms, the most important thing is what you achieve. And is it effective, and is it also cost effective? And this is what is of interest to all of us. And there are no diverse views on this. After all, we all want the same, to improve the health outcomes of the population and to be able to afford to do so in the best possible manner.
Yes. So there's a lot of interesting questions and comments in the Q&A. Unfortunately, we don't have time to answer all of them. We'll try to get back to some of them offline if we can. But there's also questions about, should we talk about policies being citizen-centered rather than patient-centered to create a more broader awareness, the importance of technology like telemedicine for equity. There's a question about new innovative treatments such as cancer, if the cost of drugs is a problem. There is also, should we invest more in primary care, looking at the aging population? That's one of the key investments. Anyway, so those are some of the comments that have been made. I would like to get back to the panel because we only have like 1 minute left. A very short round, all of you. If you have one priority recommendation, very briefly, to enable increased investment in health that brings benefit to society, what should that be and who should do it? You can direct it to someone who should do it. So I will start with Denis, if you have one key thing.
Well, let me be short. I think what's important is to make sure that the actors of health and finance talk the same language. And this is one of the things that we wanted to have in this report, have the figures there that everyone can use. And Dirk and Boriana have emphasized that these figures exist all over Europe. There are plenty of excellent reports about it. Make sure that you use the same base of dialogue. Second is make sure that the long-term planning is not forgotten. It's not only short-term budgets, but long-term planning, which would involve not only health and finance, but also the actors of health financing, like health insurance, and also the major technology actors, like the pharmaceutical, like the innovative technology actors. They have a major role to play there. In these 5 diseases, there have been major innovations in the past 10 years, be it in technology or in pharmacy.
Thanks. I think we need to. So you did 2 or 3 things there. So thanks so much, Denis. Antonella, one sentence. What needs to be done and who should do it?
Early and accurate. It's early and accurate the detection. Accurate meaning that the diagnostic must be taken into consideration when it comes to cancer. Biomarker testing and NGS are crucial, but also considering health as an investment, also with the accounting system and avoiding silo budgeting. And then strengthen the collaboration between health and finance ministries is key. And I believe the European semester, as mentioned, is a very good tool to use.
Thanks so much, Antonella. Boriana, how about you?
Yes, so my recommendation will be, as I said, to prioritize the implementation of prevention policies to improve the health status of the population, which is key for healthy aging, and to implement structural reforms to increase the efficiency of the healthcare systems, and by so doing, to enable the population to access both higher quality and high value healthcare.
Thanks so much, Boriana. And Dirk.
Thank you, Thomas. So I hope for health systems to consolidate recent increases in the spend on preventive care, including for non-communicable diseases. Thank you.
Thanks so much, Dirk. That was very much to the point, and I think those will be the final words of wisdom from this FPI webinar on investing in health. The need to find room for smart health investments will certainly only grow during what is shaping up to be a really critical year for Europe in many ways. And it's the view of FPI that investing in health is not only important for the sake of patient and population health, but that if it's done right, as we've been discussing, it will also make Europe more competitive, more prosperous, and more fiscally sustainable, helping us to deal with all these other stock challenges that we are facing. So we therefore hope that this important debate will continue, both here in Brussels and also at the national level. You can find the full report on the FPI website. Don't hesitate to reach out if you have any questions or would like to discuss. And with that, we're already 3 minutes over time, and I would like to thank again our excellent panel. I would like to thank the speakers and authors from Our Health Consult who worked very hard on this report, all the members of the FPI Health Systems Working Group and its chair, Boris Assayas, for their support. And of course, all of you who tuned in to listen and to take part in this discussion. Thank you all, and have a really good rest of the day. Thank you.
Thank you. Bye.
Thank you. Thank you for having us. Bye-bye.